Good afternoon, everyone. We'll just start momentarily. I see a lot of people are starting to join. Um, Allow them to give them one more minute before we begin today's webinar. So welcome, distinguished guest, to UNITAR and Empower School Health's webinar on data management and health procurement and supply chain. On behalf of UNITAR, my name is Stephen Joyce. I am a project coordinator at the Division of People and Social Inclusion. Today, we will explore the impact of data-driven decision-making in healthcare procurement and discuss how data can be a catalyst for positive change in healthcare supply chain. Today, I have the pleasure of introducing Professor Andy. He is the Professor of Public Health and Director of Training and Capacity Building at Empower School of Health. He has over 30 years of experience working with major international funding institutions and bilateral donors, medical procurement and supply chain management in low and middle income countries. His key focus areas include effective management on pharmaceuticals, vaccines, and medical commodities, and especially the implementation of programs for the introduction of new medicines and vaccines for neglected tropical diseases. He's provided support to various EPI vaccine programs in Africa, South and Southeast Asia, and also served as a technical advisor to the Asia Pacific Leaders Malaria Alliance on the medicines and health commodities. Before opening the floor to Professor Andy, I would like to invite all of you to do just a short ice-breaking poll to get a sense of understanding where you are all at. So I'll just open up the first poll right now. Just to confirm, Professor Andy, you're receiving the poll as well?
Sorry, I have it on screen, yes.
Wonderful. So we'll just give everyone just a couple more minutes just to be able to answer these questions accordingly. Okay, we'll just allow one more minute. I see quite a lot of you have answered the questions. For those who haven't already, I invite them just to go very briefly through the poll. All right, I shall end the poll and see where you are all at. So I see that we have a bit of a more male-centric audience today with 64% and 36% females. Majority of you are between the age demographic of 30 to 40 to 50. The majority are here in Africa and Middle East, with some in South and the rest of Africa, Americas, Europe, and the rest of the world. The academic background with 31%, primarily in pharmacy diploma, bachelor's degree, which is very good based on Professor Andy, your resume, along with pharmacy master's, a little bit in management, public health, engineering, logistics, supply chain, good. And regarding experience, we see that a lot have had minus 5 years or 6 to 10 years in the industry, and quite a wide spectrum in terms of the sectors and national government, NGOs, private sector, and then academia, and state government being a bit of on the lower side. This is great to hear. In the area of work, you have a lot of focus on supply chain, so this will be very useful for Professor Andy to target you in throughout the webinar. And also great, a lot of you also work in the hospital and in wholesale distribution. And then the other, I suppose, is more open-ended. Wonderful. All right, so thank you for providing your input. This is very useful for us to collect this data accordingly to see where you are ultimately coming from so that we can target the audience towards you accordingly. So I just want to express my gratitude for Professor Andy for being here today. Before he begins, I'd like to invite all of you if you have any questions, please leave them in the chat, and we'll leave this for a Q&A session at the end. We will also provide another poll at this point in time as well. With that, I am pleased to allow Professor Andy to the floor to take us forward with his presentation on data analytics and healthcare supply chain management. Welcome, Professor Andy. The floor is yours.
Greetings and welcome to everyone, wherever you are in the world. Good evening, good afternoon, good morning. In the next 30 minutes, I'm going to try and take you through a little bit about healthcare data analytics and data management in healthcare supply chain. The first point is that the data analytics in healthcare supply chain is not new. More than 2,000 years ago, there are papyri and reports from Cleopatra and from the Roman army of logistics management of medical supplies. Even in the modern era, we published the Managing Drug Supply, Volume 1 in 1982. So we've been talking about data analytics in medical supply chain for a long time. But suddenly it's become fashionable. There's great pressure to move now. Everybody wants to know about data analytics in medical supply chain. And if we ask why that's the case, well, the obvious answer is, of course, COVID. But it's important to understand COVID did not create the need for data analytics in the medical supply chain. It highlighted the deficiencies and the appalling state of data management in our public sector healthcare supply chains. COVID didn't cause that. It only highlighted how bad we were. We weren't just not prepared for a pandemic. We had no way of ever becoming prepared for a pandemic because we didn't know our supply chain status. We didn't know what we've got, where we've got, and its condition. And that's a sad reflection on the public sector medical supply chain. And my message today is that has to change. And we have to bring data into management decisions. And it is possible It can change. So my overall premise today, which I'll expand on over the next 30 minutes, is that our public health supply chain, procurement and supply chain, is nearly dysfunctional. It is improving, but it's only improving very slowly. And it's totally failing to keep pace with the demand for the type and the volume of location of new health products, especially in the area of poverty-related neglected diseases. We just think about the sheer volumes that COVID brought to us, the volumes of PPE, the volumes of vaccines. They were massive. The COVID vaccine program was 10 times more volume than our EPI. How can we cope with that kind of volume if we don't have data management? The reality of many of our public sector systems is that we're trying to use obsolete techniques. We have little reliable data, and even the concept of data use and data analytics has been ridiculed. And I'll explain that in a few slides, exactly what I mean by that. But even in this sad picture I have painted, my message is it is still possible to utilize supply chain analytical methods to drive improvements, to advocate and improve data collection, and introduce modern methods of supply chain management. My overall message is you can make a difference by promoting and advocating the literally vital, life-saving role of supply chain analytics. If we look at the challenges and the opportunity, it's not just old professors who are telling you that data is a major problem. Many organizations already recognize that. It's the #1 problem in the public sector medical supply chain. We don't have data. When we do have data, it's not reliable or it's in silos. It's locked up. It's not being shared. People who need it can't get to it. But it's worse than that. In many countries, there's no process even to capture the data, even to acquire the data. There are no processes in which information can be fed back from the data to undertake management decisions. And even when we unlock data from paper tools, and many of our systems, around 50%, are still manual collection, it still remained very weak because we're not integrating and analyzing that data. Two years ago, we did a survey during the middle of COVID of countries in Southeast Asia to see how prepared they were for COVID and their response to the COVID pandemic. What we found that only a quarter of countries had any supply chain data at all. Most countries didn't know what their stock out rate was, how many days they were out of stock, what their expiry rate was, what their stock value was, how much have you got in the warehouse, what's the cost of operating the warehouse, what's your holding cost, their transport capacity, their lead time, and their procurement value. They had a government budget for how much to procure. How much did you actually spend? Don't know. So continually in the supply chain, we're taking major management decisions involving millions of dollars with no information. Can we make a sound case for investing in the supply chain? Should we take out one tier of operation and go from central to district, take out province or state? How much should we invest? What's worth strengthening? Is direct delivery make sense? All of these decisions, we have no information. We're guessing. All the time we're guessing what's right for our medical supply chain. One of the concepts that is used throughout the private sector is the economic order quantity. And we use this as an example. So basically, is it better to buy little bits often or a large amount infrequently. And we have to balance the cost of discounts from larger quantities with the cost of operating the warehouse and storing the item in the warehouse. And when we plot the charts, we find we come to an economic order quantity. What's the most economic quantity to order? And on the screen towards the bottom right, you can see the formula. It's a square root of the annual use, the incremental ordering cost, the holding cost, and the projected net acquisition cost. But if we look in the public sector, this whole system is ridiculed because they say, well, we don't know what the holding cost is, and we don't know what the incremental cost is. What's the discount for larger quantities? We don't know. We buy at annual tenders. We've got no idea what it is. What's the total cost of acquisition? We don't know. So we're taking the square root of a guess and dividing it by a guess and multiplying it by a guess. The private sector doesn't operate that way. They have the data. They know what their holding cost is. They know what their acquisition cost is. They can do data analytics. We've been operating our public sector supply chain systems for more than 30 years. Surely we should be better by now than this. Just guessing all the time on what is appropriate. And the point around this is data analytics works. It's not an old professor telling you it's a good idea. There is published, proven information. Typically, using data analytics in a public health sector supply chain will save you around 20%. 20% of the cost. Can you think of anything else that will bring that level of cost saving to you? But we're not using it. We're still at 50% on paper collection and manual systems. Not only that, we're not advocating, we're not pushing for data management, for data collection and data analysis. It really does make a difference. And because we're not collecting that, we're failing to improve. We're not getting better. We are getting a little bit better. We're getting slightly better. But we're not moving forward in the way that the private sector supply chain has moved forward. They've massive advances, massive cost reductions in their supply chain. We're not doing that because we're not using data. We're not measuring, we're not collecting, and we're not analyzing the data that we've got. We don't know what our critical paths are because we haven't got the information. It's blocking us from improving. It's not just that we are poor, we're not going to get better until we adopt data management and data analytics. Well, just a minute, Prof. That's a good story. It's interesting, but we don't have any data. We haven't collected any. How can we do data science if we haven't got any data? And there are really two approaches to this. One is to say, I can't do it until I've got some data. So until I've collected data, there's nothing I can do. I don't accept that. My point around is you don't have to wait for what's known as big data. You don't have to wait for massive computer systems or artificial intelligence or blockchain to arrive. You can start now. There are things you can do now using what we call little data. That's just small amounts of data collected from surveys and from other sources that we can work with. It's not ideal, it's not perfect, but it gets us started and it gives us an improvement. Don't wait for blockchain and artificial intelligence to arrive. Start using the data that's available to you, even if it's not directly collected in your system. So to collect this data, we need a multi-pronged approach. We're going to start with little data. And the most common source of little data is sample surveys. We just go out to 10 health centres and see how well they're doing. And see what their overall data collection is. Second one is to use proxy data. That is, I'm going to use data from similar systems. There might be a neighboring country, there might be a neighboring province that you can use their data as an indication, as proxy data, to give you some idea to get started. Then to undertake a systematic system of strengthening. You can use the theory of change to instill, scale, and sustain data management, data collection, and data analytics. You can also use the technology to leapfrog. Now there are many sensors which can record data directly. The simple one is barcode. Just scanning barcode gives you complete information straight away. I don't have to manually type in data into a computer system. It can be collected. Automatic temperature sensing can give me information about the warehouse condition. Lots of data available directly into my computer system. Doesn't require any degree of processing. That's the technology leapfrogging. Going forward, on the screen you'll see a report about it. So, three-pronged approach. Using little data and proxy data to start a systematic strengthening of data collection, and then embracing the technology for data leapfrogging so that data comes directly. I don't have to process anything directly from sensors and measurements into my system. There's lots of evidence to show that data analytics works. We've got 3 references on the screens there. It really does bring, and it brings it in many ways. The algorithms that we use can improve forecasts massively. We know how difficult it is to undertake a forecast, because if we use consumption-based forecasting, that's what we used in the past. But we need to predict the future, and predictive forecasting is very difficult. But data analytics can assist us and improve our forecasting, even in those areas where we don't have a lot of reliable past consumption data. It can also help us to track drug shortages and identify them quickly. It can bring a massive improvement into our overall supply chain operation if we know what's happening. And data analytics gives us the potential to do that. And we don't have to leap straight in to a fully computerized operating system. We can start step by step with early digitization, move into emerging digitization, and then more advanced data analytic systems, moving stepwise through the system. Important point here is to get started, to start to embrace data analytics, data management, data collection, converting it to information to take management decisions. So in order for that to happen, we have 4 critical actions that have been identified. We need a roadmap. What is our stance on digitization? Where are we going to go? What data are we going to collect? How are we going to collect it? What are we going to do with it? We have to build relevant capabilities. Most of the people on this webinar today are pharmacists. You probably didn't learn a lot about data management and data analytics at pharmacy school, did you? It's a new skill we have to acquire. We have to become familiar with it in order to operate the medical supply chain. We've got to get stakeholder commitment. There's many people involved in the supply chain. We've got from the very first identification of the product, into quantification, into procurement, supply, and the users. All stakeholders need to be on board with our digitization, with our conversion into data analytics. And we have to ensure interoperability with existing national structures. Many of you will be aware, we've got computers that can't talk to each other. They use different systems. We can't have that in a national public health supply chain. Every piece of equipment has to be able to talk to every other piece of equipment. And that needs careful design and specification of our data management, data collection, data analytics system. using standardized formats throughout. It's a big undertaking, but we can get started, we can advocate for it, and we can move on. Some donors have already recognized the need for data analytics, and PEPFAR helped to emphasize that need. If we look at the donor that's most notable on data analytics, of course, it's PEPFAR, the USAID President's Emergency Plan for AIDS Relief. 50 countries, $85 billion. Of course, we had to have data management to manage and control that massive level of provision. Moving into real-time predictive analysis. Not just relying on past use. If we'd have relied on past use for the HIV/AIDS epidemic, we would never have been able to scale up. We had to predict the future using commodity sensors, direct readings from the warehouse instead of going to count boxes. We know immediately what's in and what's out and what's on the shelf all the time. This is the leapfrogging which the technology can bring to you. I talked about survey data. Here on the screen is some survey data. These are just taken from a few little areas, a few little clinics. Is it worth investing in road networks? If I invest in road networks, I improve my distribution. Would that bring an improvement in my supply chain? Well, I can look at a small survey, see if it's got a real impact, and use that survey data as my little data to start the process of saying, looks promising, looks good, maybe I should collect more information. What about expanding the workforce? Section C here. If I had more supply chain staff, does that bring me a better operation? Again, I can use survey data, just a few areas to help bring that along. What about bigger vehicles to transport? Will that have an impact? Again, a survey, small scale, collect the data, analyze the data, helps me make the decision until I know exactly what my transport capacity is and what my ability is and what I need in the future based on the volumes. Let me ask, I'm going to put it in the Q&A as well. How many of you know what the volume, cubic meters, of your central warehouse is? How many of you know what the volume, cubic meters, of your clinic is for storage, clinic or hospital? How can you possibly plan when you don't even know what you have? The data management, data collection at the most basic level is essential. And we can use this survey data to help tell us what we have and where we can go. Proxy data, perhaps the prime example in recent years of the use of proxy data, is the COVID pandemic. During the COVID pandemic, we need to forecast what commodities we need. But we've never had COVID before. How can we possibly know what we're going to do? How many cases are we going to have? How can we do morbidity quantification if we don't know how many cases we're going to have? I can't do consumption quantification because I've never used it before. So we had to put together proxy data. For most countries, we had to use the little bit of data we had from the high-income countries, the US and Europe. World Bank and Imperial College London put together epidemiological models. This is the proxy data. Using database from SARS, from a similar disease to COVID, an avian influenza, to forecast. And then a Delphic expert team put together algorithms for the supply requirements based on the models. We didn't have COVID data, so we had to use proxy data. That was then combined together into an essential supplies forecasting tool. We didn't have data, but we could still do forecasting. We can still do data analytics using proxy data. And we put together the essential supplies forecasting tool for COVID. was Excel-based sheets interlinked with preloaded information to forecast how many gloves do we need, how many gowns, how many aprons, how many masks, what medicines do we need, what equipment do we need. We put that all together using proxy data. Data from SARS and avian influenza, and a little bit of data from the high-income countries. So even without specific data, I can still undertake data analytics using the little data and the proxy data. So during COVID, there were lots of problems, but we'd already prepared for them. We'd already got best practices in supply chain preparedness. I'm sure none of you had read it before COVID, and even now, not many of you may be aware of it. But reports, systems, techniques to respond were available, but they all need data. What's so special about COVID data? It's 10 times the scale. It's massively scaled up from everything else. We look every month, 90 million masks, 30 million gowns, goggles, 76 million pairs of gloves. Massive scale up from what we're used to, but we can forecast using proxy data and data analytics. Here are examples of the quantification tool, and towards the top left, you can see the medicines. The medicines were quantified using this proxy data. How much chlorhexidine do we need? How much dextrose solution do we need? It's there. What about equipment, nasal cannulas, ventilators? That was all done using proxy data. Medical equipment, how does it number of cases? How much do we need in cost? The budget prices were included. So you enter the number of cases for your country. That's forecast from World Bank and the London Imperial College. On their algorithms, put those in, and we get a quantification. Not perfect, but at least we can do it using the proxy data. And this example really to illustrate the benefits of getting started, of moving, using the data that's available to us. Well, did it really work? Well, it got better as time went on. The first essential supply chain forecasting tool was difficult, but 3-4 months later, it got better. A year later, it was excellent because we were collecting data all the time, real data to improve. So you can start on proxy data and collect real data to improve. But even on the proxy data, there were success stories. We signaled to the market the scale of increase that was needed so manufacturers could scale up and get ready. Still a problem, still short supply everywhere, but at least we had some kind of forecast to work from, some kind of analytics, some kind of predictive technology to use. Well, that's all good stuff. How do we go about getting this data collection, data management, data analytics into our system? And we use the theory of change, a management technique. Recognize the issue. What are the biggest obstacles? What's the solution to those obstacles? What are the preconditions that we need to satisfy? And what are the actions? So the point around this is data analytics is not buying a new computer. It is about systems, about management systems, about management operations. That's what brings the change. Yes, we need some IT as well, some information technology, some hardware. But fundamentally, we need the systems, the policies, and the people who can operate them. That's the overall theory of change, a management change. We need to move away from buying a computer fixes all the problems. No, it doesn't. Many of you will already have computer systems for your supply chain, which are not really appropriate and don't function that well. We need to start with the management change and then look at what IT we need to support us. So this theory of change, there's a link on the screen to a video, and this is about how we get trained people. We need staffing, we need skills, we need working conditions, we need motivation all the way through. That's how we drive this theory of change. How do we get staff? How do we get people who are skilled? As I've said, most of the people on here are background in pharmacy. We'll need to acquire the skills in data management, in data analytics. And the stages of the intervention, well, of course, we're going to start small, going to instill, probably with a pilot, and we look at going to scale, then we look at sustaining it. What are the preconditions? We need trust. Absolutely, we need to start with trust, because right now we don't. Not everyone trusts that we know how to manage data. Can the supply chain be secure on the data? How many of your computers are riddled with virus? If I'm going to transfer information to them, do I have confidence and trust that you can actually operate it and keep the data safe? There are ransomware attacks daily, even on public health supply chain systems. How am I going to get them secure if I don't have confidence and trust in the people operating the system? I need the knowledge and skills, and many of our supply chain staff don't have them. We need to acquire them and bring people in who can help us in those areas. Of course, we need incentive and motivation, always a problem area. We also need the structures, the reporting, the administrative, and the financial mechanisms in place that promote data use. What's the cost of your national warehouse? What does it cost? Most people have no idea. In most countries, no idea. Well, all the bills are paid by the Ministry of Finance. They have all the data. That's not helping you figure out the data management costs. It's not helping you figure out data analytics. You need to be able to have financial resources, and that means access to financial information. You need the systems and the tools for processing and reporting and analysis, and of course you need policies. National, subnational, international. Mention international because many countries have already signed data agreements on an international level. But often people in the country, especially in public sector, don't know about it and don't know what those conventions involve. Conventions about data standards, the format, the structure of the data, about data security, how it will be kept. And I've all come back to the start, which is the confidence and trust in the operation. All of that needs to be in place. We don't need to wait for all of it to be in place. We can start small now and advocate and become aware of these requirements. So, advocate, we make a small pilot, we look at moving to scale, and then we go to practice. Sounds easy. It's very hard to get started. I've got to convince a lot of people to pay for training in data analytics, to start to pay for data collection and data management, and all the staff required for the analytics to make this work. It's not just buy a few computers. It needs the whole systems to be in place, and it needs staff who can operate those systems with skills and knowledge. Leapfrogging technology, instead of processing data, use the sensors to collect it electronically, automatically. We're looking at smartphone applications now are becoming more popular, data scanning, barcode scanning, even on a handheld smartphone can help. That can bring it in. Ease of tracking of data, ease of reporting. There are many examples of how mobile phone reporting can help track what is where and when. And that can bring already a massive boost to our overall data analytics. In many ways, we need to learn from COVID, but COVID is also a boost to us. It's made a lot of people realize the huge problems we have in supply chain, the huge neglect that supply chain has suffered, and how we really got to reform and move forward. If we want the actions of informed decision, we need data and we need to analyze the data. We need to start taking informed decisions because there's millions of dollars involved in our medical supply chain commodities. COVID is helping to drive the politics, is helping to drive the agenda by having highlighted these serious problems and deficiencies we have. Well, does it really work, Prof? Is it talking a good story here, but does it actually? Well, there are many examples. One is from Zambia, when they introduced their electronic supply chain management information system, saw a huge improvement. Districts now report commodities, overstock districts can transfer to understock districts. It's about building that local capacity and systems strengthening. It really works. It really can make a difference. Well, okay, Prof, but if it's so successful, what's it got to do with me? It's all working. I don't need to do anything. Unfortunately not. Right now, all of these are at small scale. We've not yet reached the tipping point where the advocacy, where the push for data analytics is going to take place nationally. It needs all medical supply chain practitioners, and that means you, everyone here on this webinar, to advocate, to explain, to educate, to build trust and promote the major concepts. You do not need a data warehouse. You don't need big data. You don't need artificial intelligence to come. Little data, proxy data can work, and you can start on that now. But most importantly, it's not enough that you know about this. You have to advocate and promote the benefits of data analytics. You don't need to be a medical doctor to help save lives. Data analytics saves money, improves stock rates, and saves lives. So my message to you now is go and change the world. And I think we have a little time to take question and answers. Okay, let's see what we have in the QA box.
Thank you, Professor Andy, for your exhilarating session. And it's always very informative to have you here and host these sessions with us. As you mentioned, we'll now move towards the Q&A portion. And just looking at some of the questions that were asked here, perhaps we can start with this one question that is here. What do you think can be done now to ensure that countries, including other stakeholders such as private sectors that have data on the spot, or public and private sectors in health and supply chain, how can they work closely together to collect data effectively?
Okay, I think the point there is to start to work together. Too often, the public sector is afraid because of the allegations of corruption and other action. They don't want to be in close contact with the private sector. We have to change that and operate together with the private sector, ensuring probity, but being able to share information from the private sector to us. If they've got it, it can be shared in a way which does not compromise any patient information or any commercial information. So if, for example, the private sector reports an increase in the amount of TB medicine, it's an indication there's more TB in the country. Public sector should pick up on that and look at that area. So it's possible to work together with the private sector if probity if clear rules are in place. Some countries are better than others at doing it, but I think that's the starting point, talking with the private sector, and that includes wholesale distributors, pharmaceutical wholesale distributors in the country. What are you seeing in increasing? What's going more? That's the first step in the cooperation, and then more can come. Okay, I think we can take another question.
Thank you so much, Andy, and it's great to hear the role of the variety of different stakeholders. Before we begin in the second question, I just wanted to open up the polls once again um, uh, to each of the participants that are here, just based on their experience here throughout the webinar, and then we will proceed again with more questions. So there's 5 questions there. We'll allow you just another minute just to give some time to be able to answer them directly. Okay, just one more minute. I see quite a lot of you are answering these questions, and we'll just allow some more people to give some time just to go through each of the results, and then we'll proceed again with the other questions. Okay, thank you all for answering these quick questions. I see the majority of you found this material useful. That's always good to hear. Great job, Professor Andy. I think that's always good feedback to have. Are you interested in exploring digital health courses? The majority of you said yes, so that's great to know. And specifically, what courses and training? A good chunk of you said data management, supply chain, global health, digital health, and then a bit of a wide spectrum here between cybersecurity, pharmaceutical, waste management, health leadership, and so on and so forth. Which types of courses are you interested in? Online certificates for 2 months or an online diploma of 6 months? That's good to know. And then also a fair amount for 24-month master's programs. Lastly, are you interested in new careers for data management and supply chain? Yes, is a good majority of what I heard from you within your own organization or a new organization, and also with the UN. And that's very good to hear, as a good majority of the students that we've actually obtained in our joint UNITAR and Empower School of Health master's programs and also postgraduate courses have led on to build very prosperous careers within the United Nations, either at WHO or upon other organizations. So very good to hear that you're interested in taking these courses, and I hope that future enrollment in some of these programs might allow you to build these careers that you all seek. So just going back to the questions, Professor Andy, you had this one question here that I thought was good to bring up. How do we develop a sense of responsibility and motivation in lower levels of supply chain personnel?
Okay, well, I think the answer is training, training, and training, but more specifically, responsibilities, because often it's not explained. Many of them don't know what the products are they're handling. They don't know or understand the importance in the medical world of what's going on. And that needs to be explained as part of the training. Warehouse staff in particular often don't understand the products they're handling. They don't have the technical background and knowledge. It needs to be explained in simple terms. We're quite good at training senior staff, not so good at training junior staff. Much better training programs focused in a way they can understand, in a language they can understand. And I think that's the way we go. Once the explanation is there, I think motivation will follow. We see high levels of motivation in different organizations. The faith-based organizations always have high levels of motivation. And I think we can learn from that as well. By being inclusive with them, by making sure they're part of the community, we can bring that motivation to bear.
Wonderful. Thank you, Professor Andy. And to just touch on your first part, the role of training cannot be underestimated enough. So it's always good to hear that role in terms of being able to find people engaged. Just another question here in terms of digitization of the health supply chains. How digitized are health supply chains in the world? And how could you describe perhaps two digitizations of the supply chain and supply chain data analytics?
Okay, we take that in two parts. I think the private sector health supply chain is highly digitized all the way through. And in a part that's been like that for a very long time. So basically the patient gets billed for everything that is used. So every commodity is tracked all the way through to the patient. So that's a high degree of digitization. Every product comes to the patient with a barcode, it's scanned and it's moved in. So from backwards from the patient all the way through procurement, it's tracked, it's completely digitized. Public sector, we see North America, Western Europe, highly digitized supply chain systems again. But in Europe, more decentralization of the systems, largely operated by private sector, except the UK, which is of course all public sector. But high level of digitization. Outside that area, we're seeing rising digitization in Asia, but regrettably still very slow in Africa. Private sector in Africa is digitizing fast. Public sector is going very slow.
Thank you, Professor Andy. My apologization. There's a slight delay, so I'm just trying to catch up to you. This is a question I think perhaps that's useful for academics in many ways, but one of the questions asked for any recommended references that would help establishing data management systems.
Yes, there's a WHO guide for data management and for data policies. There are also published guides on developing a national data policy. That's one, that's that top level for the entire country, all areas, not just medical. And then there's policy for the medical side of it, which includes supply chain. So there are WHO guides on data policies for developing a national data policy in the health sector. They're quite clear, they're quite detailed, they're certainly easy to access online from WHO.
Very good. And that actually answered another question in terms of being able to create a national plan for certain countries. So I'm glad that you were able to touch off on that, particularly. Um, just another question, perhaps, and maybe this is answered by reviewing that WHO document that you just referenced. But how can perhaps the everyday person provide any volunteering services to start creating their own data management strategies within their own organization, within their own personal affairs, um, and so on and so forth, perhaps just at maybe a beginner's level. Um, what do you think a key lesson for them would be?
I think you start by identifying your key problems in the supply chain. And most countries will have had a survey, will have had a review using either the Global Fund or the World Bank or the WHO supply chain analytical review. So where are the key areas of the problems? Then you look at how data is going to assist you resolve some of those problems and then focus on those areas. Instead of a massive overarching approach, start small, look at a particular area. We have a problem on expiry rates. Okay, what can we do about expiry rates? Start by measuring them. When you measure them, and that's relatively easy to do, how much is expired, record it, add it up, and see what the actual rate of expiry is. Most countries don't know what their rate of expiry is, just that small. Is it really a problem? And when you look at the value, you often find that the expiry rate is not that high. It might look in bulk large, but compared to the volume that you're handling and the value that you're handling, it's often quite small. So that's where information becomes key to making decisions. Choose one area, focus on that area, assist in measuring it. Measuring the expiry rate, relatively easy to do. Okay.
Thank you, Professor Andy, for your insights on this role. I'll just offer one more question as we're almost out of time here today. Um, what, in your experience, would you say is the main challenge for digitizing health and in perhaps more developing nations? And what kind of insight do you think you could provide for people that might be in a role of wanting to encourage that from a national government strategy?
I think it's recognition of the problem. It's just not seen as a big problem. COVID has helped to highlight that problem by exposing the weakness of the supply chain. But because supply chain is not frontline medical care, it gets pushed to the back. It's a Cinderella operation. So the fundamental problem is to advocate and bring the policies to address the issues. That's the biggest area at present. It's not fully recognized. The biggest problem in supply chain is data and the lack of data. Resolving that problem is going to require considerable investment, but that's not understood, and that has to be advocated. That investment will be returned many times over. It's exceedingly cost effective. All the studies show that. But advocating, bringing that recognition and that policy is a big hurdle.
Thank you, Professor Andy, for all your insights and answering the questions that were provided today. For those of you that didn't have their questions answered, we apologize as there's limited time. I will provide in the chat my colleague's email, Professor Samuel and Guy, and please write to him for any questions that you might have. For those who are very interested in this semester and want to learn more, I invite you to check out our master's and postgraduate programs at Empower School of Health with UNITAR, which I'll also put into the chat momentarily as well, so that you can seek these and look into if these courses are right for you. With that, I want to thank once again Professor Andy for being here today, and being able to provide some of the answers in his presentation today on supply chain. So thank you very much, Andy. It's always a pleasure to host you here today. So thank you everyone for participating. We hope to invite you back for our future webinars that we will host every month. Thank you so much.
Good night to all.